So my charge today is to review flexor tendon injuries with you. I have no disclosures. And the treatment of flexor tendon injuries, I think, really exemplifies the essence of what defines hand surgery. It requires good understanding of a very intricate anatomy, meticulous surgical technique, and then attentive rehabilitation in order to attain optimal results. To go over the anatomy briefly, there are two tendons, the flexor digitorum profundus and superficialis, going to each finger, and their names reflect their relative relationships in the forearm, wrist, palm, and part of the digit, that the profundus being deeper, the superficialis more superficial. The flexor profundus inserts on the distal phalanx, and the flexor digitorum superficialis inserts on the middle phalanx. And in the thumb, there's only a single flexor tendon, the flexor pollicis longus. Now, the classic anatomy divides the course of the flexor tendons into 5 different zones. Zone 1, the profundus tendon alone at the distal insertion at the distal phalanx. In zone 2, the profundus and superficialis flexor tendons are both within the fibroosseous tendon sheath. In zone 3, the tendons are in the palm but with no sheath. Zone 4 within the carpal tunnel, and zone 5 proximal to the carpal tunnel in the distal forearm. Zone 2 is the notorious zone, the so-called no man's land, because of the narrow confines of the tendon sheath. Briefly, the tendon sheath is made up of segments of fibrous tissue that we refer to as the pulleys. And there are 5 ring-like annular pulleys and 3 cruciform strap-like pulleys. And the odd number ones, A1, A3, and A5, are at the level of the MP, PIP, and DIP joints respectively. In zone 2, the flexor tendons run together in a closely confined space and have a very close tolerance with that sheath. And I've referred to it often like a piston in a cylinder. And because of this, it's important that repairs in this zone be very precise so as to avoid bulkiness that could restrict the gliding of the tendons. Also, careful technique and handling of the tissues is essential to minimize the potential for scar formation and adhesions. The tendons also have a dual nutritional supply, with the intrinsic vascular supply coming through the vincula that feed the tendon dorsally, and also extrinsic nutrition from synovial diffusion. Diagnosis of a flexor tendon laceration can often be made by the appearance of the hand. Normally, there's a cascade of slight digital flexion from the intact flexor tendons, the resting flexor tone. But in the case of a flexor tendon injury, there's loss of that resting posture into full digital extension if both tendons are cut, with inability to actively flex the injured finger. Now, in testing, if there's active DIP flexion present, that would indicate integrity of the profundus. But to assess the integrity of the superficialis is a little maneuver that's necessary to isolate it. So the digits that are not being tested are held passively in extension to neutralize the action of the profundus tendons, which share a common muscle belly. In this way, you can isolate the superficialis to be able to identify the action of the superficialis. It's also important to assess for associated injuries, such as to the nerve, or to the bone, or to the vessel. As far as timing of repair, ideally within the first couple of weeks post-injury, and maybe even 10 days in the case of some FDP avulsions, as the tendons may retract proximally. And if it gets too tightly contracted, it may not be feasible to advance it back distally again to repair it. If it hasn't retracted too far, then it may be feasible to still do a delayed repair, but again, earlier the better, so as to avoid the risk of getting a contracture. If you do advance the tendon too tightly, there is the risk of creating a flexion deformity, but there's another phenomenon called a quadriga effect, and that refers to a situation when you're making a fist in the fully flexed position, that the finger that was fixed, in essence, the shortened, tighter repair causes the finger to get into the flexed posture prematurely, if you will. And that results in insufficient tendon excursion in the adjacent digits to be able to completely flex them. Associated injuries may also dictate the timing of the repair, such as the need to address an open fracture or a vascular injury more urgently. When performing a tendon repair, delicate handling of tissues is important to avoid scarring and minimize adhesion formation. You should handle the tendons by the cut ends, and of course, respect the neurovascular bundles. The A2 and A4 pulleys are classically referred to as the critical pulleys for maintaining function of the flexor tendon sheath to prevent bowstringing. But Jinbo Tang has shown that they can be vented fairly extensively if needed to perform the repair. I'd say that preservation of 50% of these pulleys is probably a good rule of thumb, though, to avoid excessive disruption of the sheath. Ideally, repair of both the profundus and superficialis tendons is performed, which better restores the anatomy for gliding between the tendons and can also allow for more reconstructive options in the event of later complications. Depending on the extent of the local trauma, sometimes only one slip of the superficialis tendon can be repaired, and sometimes the superficialis may be left unrepaired altogether and only the profundus fixed. But if feasible, repair of both is preferable. A key goal with flexor tendon repairs also is to restore optimal strength of the repair so as to be able to facilitate the initiation of therapy. Surgical exposures depend on incorporating the wounds from the injury, combined with the surgeon's preference and experience. I personally am most comfortable with the exposure that I get from a Brunner zigzag approach, but I know other surgeons prefer a mid-axial approach. It's kind of a dealer's choice as to what you're comfortable with. But remember not to make longitudinal incisions that are perpendicular to the digital flexion creases, because that approach will result in scars that cause flexion contractures at those joints. Again, the challenge with zone 2 is the need to work within the confines of the flexor tendon sheath. Sometimes the injury has created enough exposure, but sometimes, as I mentioned, Jinbo Tang has demonstrated, venting of the key A2 and A4 pulleys is needed, and this can be fairly substantial. It's also important to recognize that if the injury had occurred with the finger flexed, as shown in the bottom right picture, the level of the tendon injury might actually be more distal than the skin and sheath wound once the finger is extended, and this will impact the exposure that's needed for the repair. And when we make these approaches, we try to preserve the pulleys where feasible, threading through them, but again, certain areas may need exposure to be able to provide access to facilitate the repair. The repair itself is performed with non-absorbable sutures that are placed in the cylindrical core of the tendon, and usually 3/0 or 4/0 sutures depending on the size of the individual tendon. At the level of the flatter superficialis tails, closer to their insertion on the middle phalanx, 4/0 or 5/0 horizontal mattress sutures are typically used. And as far as suture material, ethibond, super mid fiber wire, proline, these are all commonly used materials for the core sutures. But perhaps the key point to take home from this talk is that the strength of a repair is proportional to the number of strands across the repair site. And thus the number of strands has the most significant effect on the strength of the repair. Of course, the greater the number of the strands, the more complicated the repair can become, which is evident on this slide. This shows just a variety of different core suture techniques. And many have been described, and some of them can be extremely intricate, but again, the take-home message is that the strength is proportional to the number of strands across the repair site. Biomechanically, placement of the core sutures in the dorsal portion of the tendon is stronger, but the intrinsic blood supply to the tendon also enters dorsally through the vincula. You can see the vincula depicted over here. And so usually the core sutures are placed more centrally so as to not interfere with the blood supply coming into the tendons. Some of the multi-strand repairs may distribute the core sutures along a wider cross-section of the tendon as well. When tying the core sutures together to approximate the tendon ends, it's essential to avoid gap formation, which is incredibly detrimental to the strength and also healing of the tendon repair. And in fact, given that there can be some tissue creep that may lead to gap formation in a repair that initially looks like it's very nicely approximated, some surgeons have advocated making the repair just ever so slightly bunched up at the initial stage to account for this later creep. Epitendinous suture is routinely performed on tendon repairs within the sheath, which adds some strength to the tendon repair. as well as smooths the edges and reduces some of the tendency toward gap formation. A smooth 6-0 or 7-0 suture such as nylon or Prolene is typically used. And in his meta-analysis, Dr. D noted the benefit of the epitendinous suture, reporting an 84% decrease in the reoperation rate. In terms of the steps of the repair, you need to retrieve the ends of the lacerated tendon and bring them together. And if the proximal end has retracted proximally, it may need to be rethreaded back into the tendon sheath. And a small rubber catheter or a feeding tube can be pressed proximally from the level of injury through the sheath to recover the end of the tendon. And you may need to make a separate incision in the palm to recover that proximal end of the tendon. And then using the tails of the core suture that's placed in the proximal end of the tendon, it can be connected to the tubing and reinserted into the sheath and brought back or advanced to the level at which the repair needs to be made. Sometimes to get the tendon back in through the pulleys, you may need to dilate the pulleys. You can use different sounds or a clamp to slightly dilate. And if the injured tendon end is very bulbous, sometimes trimming it or tapering it slightly can facilitate its reinsertion into the tendon sheath. Once advanced distally, the tendon sheath can be stabilized against retraction by the use of a 25 gauge needle to pin it to the sheath and keep it from pulling back away. It's also important to recognize that the superficialis tails at this level may be dorsal to the profundus tendon. Proximally, the FDS tendon is volar to the FDP, but at the chiasm of Camper, it splits. You see it down here in the lower right. And as the tails of the superficialis progress distally, they rotate around the profundus tendon and are actually dorsal to the tendon as you get further distally. And so at that level, the superficialis may need to be repaired first as it lies deeper than the profundus. Essential to the successful outcome of flexor tendon repair is the post-op rehab. And the goal is to start motion early, within a couple of days, to minimize adhesion formation and to avoid stiffness. Associated injuries may alter the rehab approach and also have to be cognizant of the patient's ability to comply with a regimen for the rehab. But the general approach is to protect the tendon repair while allowing for motion early on. In the past, regimens consisted of dorsal block splinting for 4 to 6 weeks, with primarily passive finger motion, such as the Duran protocol, or active extension with passive flexion, as in the Kleinert protocol. But with the advent of stronger, as a multi-strand repairs now, active motion is being initiated much, much earlier in the recovery process. And there's a nice review article that came out in the August 2019 Journal of Hand Surgery by Clifton, Bookman, and Proxima, which goes over the various tendon rehab protocols. This slide depicts controlled passive motion of each finger joint within the protection of a dorsal block splint. But again, more modern protocols go beyond using only passive motion and incorporate various degrees of active motion. Besides trying to minimize adhesions, active motion also creates some tension on the repair site. And this has been shown to better promote tendon healing, again, provided that there's no gap that's forming. In an effort to increase the overall tendon excursion, protocols have been designed to vary the wrist position as well as the digital position in the rehab process, as shown in this slide. And in the bottom part of this slide, the place and hold maneuver is also demonstrated, in which the fingers are first passively flexed, after which the patient is actively holding them bent with just enough force to keep the fingers in that flexed position. In effect, a gentle active approach. What's the evidence with regard to outcomes? There have been some meta-analysis reviews that have suggested that passive regimens alone lead to less motion. Also, that active protocols have a higher risk of tendon rupture, but also that perhaps the complication rates are not all that different between older and newer techniques of repair. But it's really difficult to say definitively, as there's so much variation in study design, the techniques, the different protocols that have been used within these studies. And so this really highlights the need for more studies. But I think, again, that the key take-home points are that multi-strand repairs are stronger. They allow for earlier institution of active motion, which is, again, the trend now in the rehab process. And then ideally, this should facilitate fewer adhesions a more rapid and complete recovery of motion and function. Looking at a specific type of tendon injury, there's the Jersey finger, not named for my home state of New Jersey, but it's named because of the common mechanism of grabbing the evading opponent's jersey, such as in a football game. And what happens here is the actively flexing profundus tendon, trying to make that grab, is overstressed by the forcibly extended distal phalanx. And this two opposite forces in opposite directions avulses the flexor digitorum profundus tendon from its insertion on the distal phalanx, with loss of active flexion of the DIP. And it most commonly occurs in the ring finger. Leddy and Packer had developed a classification system. In the initial version of it, it had described three types of injury. Type 1 being a purely tendinous injury in which the avulsion can retract as far proximally as into the palm. And then two types of bony injuries, a smaller in type 2 and a larger bone fragment in type 3. And these bone fragments can sometimes hang up on a pulley, which limits the proximal retraction of the tendon. There are also the type 4 and 5 classifications that were later added that denote fractures with tendon avulsion off of the bone fragment in type 4. And then there's comminuted bone injury in type 5. The more proximal the retraction, as into the palm with a type 1 injury, the more urgent the repair within 10 to 14 days before the muscle becomes too contracted to permit readvancement of the tendon. Now, sometimes these cases present late, and in late cases, it may be better not to risk scarring up a well-working superficialis by passage of a tendon or graft through it, and thus disrupt satisfactory PIP mobility that's being provided by the superficialis. But if the distal joint is too hyperextensible from loss of the profundus, DIP actually, the fusion of the DIP may be a better option. To repair an avulsed tendon, there are different variety of anchoring techniques. It can be reinserted onto the distal phalanx by the use of a pull-out suture or fixed by use of a suture anchor. Complications specific to tendon repairs include rupture, such as in this case in which the patient started using dumbbells a little bit more prematurely and then ruptured the tendon repair. Other complications include joint contractures, particularly flexion contractures, and also, of course, adhesions that limit the excursion or pull-through of the tendon with consequent limitation of the active motion. In the case of limited active motion, flexor tenolysis may be considered to free up the adhesions that are restricting the pull-through of the tendon. But key is that you have to have restoration of good passive motion. That's an essential prerequisite. And the finger should have good soft tissue conditions as well. It should be reasonably sensate and be soft and pliable ideally. And ideally, flexor tenolysis is best performed under local anesthesia with some IV sedation so that the patient can be awakened during the course of the procedure and asked to actively demonstrate the tendon excursion to ensure that the tendon is sufficiently freed up. Now, if the patient can't comply with that, an alternative is to expose the tendon well proximal to the zone of the original injury, such as in the distal forearm, and then apply traction to the tendon at the proximal level to try to stimulate active motion and make sure that it's pulling through adequately. Whenever performing a flexor tenolysis also, it's important to be aware of the risk of tendon rupture. And that can sometimes occur late. And it's important to make sure that the patient is aware of this potential complication and have some options in mind should it occur. In later or failed cases, there are some salvage procedures that can be contemplated. If the tendon sheath and pulleys are in satisfactory condition, it may be feasible to do a one-stage tendon graft. However, if there's significant scarring, or if pulleys need to be reconstructed, a two-stage tendon graft may need to be done. In the first stage, a silicone tendon rod is placed within the sheath, reconstructing pulleys as needed to reconstitute a smooth gliding surface for the later definitive tendon graft. And after satisfactory healing with good passive motion, usually after a couple or 3 months, the silicone rod is removed from the pseudo sheath that's been created and replaced with a definitive tendon graft that is attached to the distal phalanx and connected proximally to a suitable motor tendon, usually a profundus tendon in the distal forearm. But before proceeding with the two-stage reconstruction, it's critical that the patient be ready and able to participate in the extensive rehab and aftercare. You need a very compliant, cooperative patient to go through with this. Sometimes accepting a finger that's motored only by the superficialis is reasonable, as depicted in the picture here, showing flexion that's attained only at the PIPs, but not the DIPs. And then finally, arthrodesis or tenodesis may be suitable options, especially at the DIP joint. The question of partial tendon lacerations often comes up, and they can be vexing because initially the tendon is going to appear functionally intact. And this is a problem sometimes in the emergency rooms as the diagnosis may be missed. It's important thus to be aware of the potential and inspect the wound, to be wary of partial flexor tendon lacerations. And if the partial injury is extensive, there's the risk of propagation into complete disruption sometime after the initial injury. A survey of hand society members had indicated that most surgeons felt that a laceration of more than 50% through the caliber of the tendon warranted repair. Sometimes there's a flap that the partial injury may cause, and that flap may mechanically catch and cause triggering if it's catching on the pulleys. And in that case, if the flap is small enough, then it can just be trimmed out. If it's larger, sometimes it may need to be repaired to smooth out or flatten the surface of the tendon. And then there's a variety of protective protocols Al-Katan had written up previously that are used in the setting of partial tendon lacerations to try to, again, avoid the problem of them propagating and becoming complete. Future trends in flexor tendon surgery include development of different devices and suture materials and methods that provide sufficient strength for immediate, unrestricted active motion and use. And this is, I think, kind of the holy grail of tendon repair. And also the use of different biologicals and other agents to try to accelerate the tendon healing, minimize adhesions, and then also the development of bioengineering of tendon tissue may provide better options for tendon reconstruction and grafting. And of course, as always, there's still room for plenty of studies to determine what are the best repair methods and rehab methods as well. And that wraps up the flexor tendon talk. And it's now my pleasure to introduce Dr.